Imagine going to sleep with a fully functioning biological thermostat, right?
Yeah.
It's keeping your house perfectly comfortable. And then you wake up to find someone has violently ripped the wiring completely out of the wall.
So total system failure.
Exactly. The furnace is firing randomly, the windows are frosting over, and the control panel is just like blinking a relentless error code.
That's a really vivid way to put it.
Well, today we are looking at the invisible chemical shockwaves of a total hysterectomy with bilateral oophorectomy. We are bypassing the structural surgery itself and really mapping the exact, immediate endocrinological cascade that hits a woman's body the second her uterus and both ovaries are surgically removed.
Right, because to map that out accurately, we're leaning on some incredibly robust longitudinal data today.
We really are.
We're going to look closely at the hormonal assays generated by the Stansic Research Group. They tracked the exact percentages of hormone drop-offs in the weeks right after surgery.
And we're pairing that with the vast epidemiological data from the Nurses' Health Study, right?
Exactly, because this isn't just about a localized surgical site, you know. It is a profound systemic disruption of the body's entire communication network.
So whether you're prepping for a medical procedure yourself, or maybe supporting a loved one, or just, have an insatiable curiosity about human endocrinology, this deep dive is going to be a masterclass in how interconnected everything is, without all the heavy medical jargon. So, okay, let's unpack this.
Yes, good.
We have to start at the cliff edge, right? The immediate aftermath of the surgery. If you're looking at the pre-op and post-op labs, the difference is just jarring.
Oh, it really is. I mean, natural menopause, it usually happens gradually between ages 50 and 52.
Right, like slowly turning down a dimmer switch over a decade. Your cellular receptors have years to adjust to the dimming room.
Yeah, that's a perfect analogy. But a bilateral oophorectomy triggering surgical menopause, that is literally yanking the power cord out of the wall.
The body has absolute zero time to acclimatize.
None. The safety nets fail instantly, and the fallout hits the heart and the brain almost immediately.
Because those organs have spent decades relying on estrogen and progesterone, right?
Exactly. They rely on them to regulate temperature, blood vessel dilation, so many things. And what people don't realize is the half-life of these circulating hormones is remarkably short.
Wow, really? Like how short?
We're talking hours. Within hours of the ovarian blood supply being severed, the systemic levels of estradiol and progesterone just plummets.
And since we're talking to an audience who gets the basics of reproductive health, we can skip the whole period and pregnancy discussion. The real crisis here is cellular.
Right, because estrogen, at its core, is fundamentally a neuroprotective and cardioprotective steroid. It actively keeps blood vessels flexible by promoting the release of nitric oxide.
Which dilates the arteries.
Yeah, okay.
So without it, the arterial walls can stiffen almost immediately. The heart is suddenly pumping against all this increased resistance.
Precisely. And in the skeletal system, estrogen's job is to inhibit osteoclasts. Those are the cells that break down bone tissue.
Oh, so the moment estrogen drops off a cliff.
Osteoclast activity accelerates unchecked. It aggressively breaks down the bone matrix.
That's terrifying. And meanwhile, we haven't even talked about progesterone.
Right. The sudden absence of progesterone removes a massive neurological buffer. Progesterone metabolites interact heavily with GABA receptors in the brain.
And GABA is your primary inhibitory neurotransmitter, right? It's what keeps the nervous system calm.
Exactly. Taking away progesterone is basically...
It's essentially stripping the brake pads off the nervous system.
Yes. You combine that with the stiffening blood vessels and a brain that is just scrambling for neuroprotective estrogen, and it completely explains the acute thermoregulation collapse.
So the intense hot flashes and night sweats, they aren't just, feeling a little warm.
Not at all. They are the result of the brain's hypothalamus completely losing its calibration. It relies on estrogen to set the body's thermoneutral zone.
The temperature range where you don't need to shiver or sweat?
Right. And when estrogen vanishes overnight, that zone narrows to almost nothing. So a tiny fluctuation in ambient temperature triggers a massive, inappropriate physiological response.
Wow. The body dumps heat through aggressive vasodilation and sweating, and then I'm guessing overcorrects.
Exactly, which causes severe chills.
That paints just a terrifying picture of the body's baseline state post-surgery. But the body is a continuous two-way communication system. The brain doesn't just passively experience this drop.
No, it actively tries to fix it.
Which brings us to the hypothalamic-pituitary-ovarian axis, the HPO axis. In a healthy system, this is like a very elegant feedback loop.
It's beautiful, really. The hypothalamus releases gonadotropin-releasing hormone, or GnRH, That signals the pituitary gland to release follicle-stimulating hormone, FSH, and luteinizing hormone, LH.
Okay, so FSH and LH traveled down to the ovaries.
Yeah. They prompt them to produce estrogen. And as estrogen levels rise, they send a negative feedback signal back up to the brain.
Telling it that everything is fine.
Right. The brain registers the estrogen and turns off the FSH and LH production. It is a perfectly balanced loop.
But wait, if estrogen is completely gone after the surgery, why doesn't the brain just stop sending signals to? Why does it send more FSH and LH instead? Like, if the thermostat realizes the heat is escaping out an open window, it just cranks the furnace harder?
That is exactly it. And what's fascinating here is that the brain has no eyes, right? It doesn't know the ovaries were surgically removed. It just registers a terrifying silence.
So there's zero estrogen coming back up to provide that negative feedback.
Right. And the pituitary gland's response to that silence is absolute panic. Because it isn't receiving the inhibitory signal, it assumes the ovaries just need to be stimulated harder.
Oh, wow.
So it pumps out massive, skyrocketing amounts of FSH and LH, trying desperately to force ovarian follicles that no longer exist to respond.
So if you look at a blood panel a few weeks post-op,
The estrogen and progesterone lines are basically flat on the floor, while the FSH and LH levels look like a hockey stick graph pointing straight up.
it's like an angry manager aggressively emailing an employee who already quit and moved to the Bahamas.
Totally.
The brain is just spamming the inbox with FSH and LH, hitting send over and over, but the server is completely disconnected. There's no one there to reply.
And that relentless chemical spamming drives up the anxiety and the physiological stress of the patient. The sheer volume of those gonadotropins flooding the system contributes heavily to the severity of those hot flashes we talked about.
So the brain is effectively trapped in a permanent alarm state, trying to restart an engine that has literally been removed from the vehicle.
Exactly.
And speaking of the engine, the Stancic Research Group assays reveal a third line on that post-op graph plummeting, one that honestly almost no one expects. Here's where it gets really interesting, because we focus so heavily on the female hormones, estrogen and progesterone, that we completely ignore a massive casualty in the surgery.
Testosterone.
Yes,
The clinical blind spot around androgens in female biology is staggering.
it really is.
Women naturally produce significant amounts of testosterone. Roughly half of a premenopausal woman's circulating testosterone is synthesized directly in the ovaries.
Right, specifically in the Schwann cells, I think.
Yep, the Vica cells, with the other half coming from the adrenal glands and peripheral tissues.
So when Stancic's team looked at the blood work just 14 days post-op, they didn't just see a slight dip. They measured a 40.3% cliff edge drop in total testosterone for premenopausal women.
Which is huge.
Right. Imagine losing nearly half your body's energy-regulating chemical in a fortnight. I like to think of testosterone in the female body as like the bass player in a band.
I like that.
Yeah, people might only pay attention to the lead singer's, estrogen and progesterone, but when the bass drops out, the rhythm of muscle tone, mood, and energy completely falls apart. It's like the idling speed on a car engine.
Cut the idling speed by 40% overnight, and the engine just stalls out when you try to hit the gas.
And the physical manifestations of that stall are severe.
Very severe. Patients frequently report profound lethargy that sleep just doesn't fix, a complete flattening of libido, and a very specific type of depressive mood liability that, honestly, doesn't always respond to traditional SSRIs.
Because the brain and muscles are suddenly starved of a critical androgen they rely on for metabolic energy.
Exactly.
So, okay, that makes sense for a 35-year-old premenopausal woman undergoing the surgery, maybe for severe endometriosis. But the Stancic data gets much more disruptive when we look at older women.
It really does.
There is this pervasive medical myth that once a woman goes through natural menopause, her ovaries just sort of shrivel up, shut down, and become biologically useless.
Right, and if we connect this to the bigger picture, the assays completely dismantle that myth.
Yeah.
When Stancic's team tested postmenopausal women...
Women who had already naturally ceased menstruation years prior.
Exactly. When they measured their levels before and after bilateral oophorectomy, they found their testosterone levels still dropped by an average of 32.7% immediately following the surgery.
Wait, wow, just let that sink in. Those quote-unquote dormant, useless postmenopausal ovaries were actually continuing to pump out a third of the woman's total testosterone well into her later years.
Yes. They had transitioned from being estrogen factories to being vital androgen factories. The ovarian, the theca cells remain highly active long after the follicles are depleted.
So when a surgeon removes the ovaries of a 65-year-old woman, perhaps prophylactically during a hysterectomy,
She is thrust into a secondary hormonal crash. She suddenly experiences a renewed wave of extreme fatigue, accelerated muscle sarcopenia, and depressive symptoms, because her baseline androgen supply was just cut by a third.
which fundamentally changes the risk calculus of the surgery at any age.
Absolutely.
We're looking at a three-pronged crash here. Estrogen falls off a cliff, triggering bone loss and cardiovascular stiffening. Progesterone disappears, removing the brain's calming brake pads. And testosterone drops by a third or more, killing the metabolic idling speed.
Meanwhile, the brain is screaming into the void with FSH and LH.
Right. And this brings us to the Nurses' Health Study and the concept of rapid aging.
Yeah, the Nurses' Health Study provided massive epidemiological weight to what we see at the cellular level. When women undergo bilateral oophorectomy, especially before the age of 50, and do not receive adequate hormone replacement, their risk profiles for chronic diseases just skyrocket.
Because the sudden loss of estrogen accelerates cellular aging processes that would normally unfold gradually over decades.
Exactly. They showed significant increases in the incidence of severe osteoporosis, coronary heart disease, and even cognitive decline.
Like increased risks for dementia and Parkinsonism.
Yes.
So what does this all mean? We've mapped out this terrifying cascade, but obviously the medical community doesn't just leave patients in this state.
No, of course not. And this raises an important question about intervention. The answer here is hormone replacement therapy, but the HRT protocol for surgical menopause, especially when the uterus is removed, is very different from the standard protocol for natural menopause.
Because the key differentiator is the absence of the uterus.
Precisely. In natural menopause, a woman still has her uterine lining. If you administer estrogen alone, it stimulates the endometrial tissue to thicken, which drastically increases the risk of endometrial cancer.
Okay, so to counteract that, you must prescribe a progestin alongside the estrogen to keep the lining thin and protect the uterus.
Right. But if the uterus is sitting in a pathology lab somewhere,
There is no endometrial lining to protect.
therefore, the standard clinical guideline for a post-hysterectomy patient is estrogen-only therapy. There's generally no oncological need to introduce a progestin, which simplifies the protocol and removes some of the side effects associated with synthetic progestins.
Interesting. And the delivery mechanism of that estrogen is heavily scrutinized in the sources, too.
It is.
The clinical guidelines strongly favor transdermal estrogen, like a skin patch or a transdermal gel, over an oral pill. But if the goal is just to get estrogen into the blood, why does it matter if it comes through the skin or the stomach?
It all comes down to the liver's role as a chemical checkpoint. When you swallow an oral estrogen tablet, it's absorbed through the gastrointestinal tract and immediately shuttled straight to the liver.
Okay, the first pass effect.
Exactly. The liver recognizes this massive influx of estrogen and responds by ramping up the production of certain proteins, including coagulation factors.
Oh, so it artificially thickens the blood.
Right, which statistically increases the risk of deep vein thrombosis, pulmonary embolisms, and stroke.
So oral estrogen essentially triggers the liver to prep for blood clots, but transdermal patches bypass the GI tract entirely.
They deliver the estradiol directly through the skin, straight into the systemic circulation. It entirely avoids that first-pass hepatic metabolism,
Wow, okay, so the liver isn't triggered to overproduce clotting factors.
making transdermal delivery exponentially safer from a cardiovascular and hematological standpoint, especially for surgical menopause, where the dosages required to quiet the brain's FSH panic are often higher.
That makes total sense. But estrogen-only HRT only solves part of the equation we built today.
True.
It stops the bone loss, keeps the blood vessels flexible, it shuts down the hot flashes, but it does absolutely nothing for the stalled engine. It doesn't replace that 40% drop in testosterone.
And this is where clinical practice is finally starting to catch up with the endocrinological reality.
Thankfully.
Many advanced practitioners are now prescribing off-label compounded testosterone creams or gels specifically for surgically menopausal women.
So by carefully titrating testosterone back into the system alongside the transdermal estrogen, they can successfully combat the profound fatigue.
Yes, and restore the structural muscle integrity and resolve the sexual dysfunction that estrogen alone just cannot touch.
Because it's really about rebuilding the entire interconnected web rather than just treating a single symptom.
Absolutely. When you view the body not as a collection of isolated replaceable parts, but as a complex chemical symphony, the path to recovery becomes much clearer.
The surgery might abruptly end one biological process, but with precise, comprehensive hormone replacement, we can prevent the systemic shock waves from destroying the patient's long-term health.
Because understanding the mechanics of that 40% testosterone plunge, or the liver's first pass effect, it gives patients the agency to demand comprehensive care.
Right. It transforms a terrifying post-operative reality into a manageable biochemical equation. When you know exactly what was removed from the system, you know exactly what needs to be replaced.
The clinical data provides the blueprint for that restoration. It proves that comprehensive HRT can effectively quiet the brain, protect the cardiovascular system, and restore the patient's quality of life.
Well, we have thoroughly dismantled the assumption that a hysterectomy and oophorectomy is just a localized mechanical fix. It is an immediate, violent disruption to the body's entire baseline. The brain panics with FSH, the bones lose their osteoclast inhibition, the nervous system loses its GABA interaction, and the body's metabolic engine stalls out without its androgens.
But knowing this exact cascade is what allows modern medicine to step in and artificially restore the balance.
Exactly. Before we wrap up this deep dive, there is one final concept buried in the Stancic data that completely reframes how we view aging. We looked at hard clinical proof that the postmenopausal ovary continues to secrete a third of a woman's vital mood-stabilizing testosterone well into her later life.
Right.
So, if the science unequivocally shows this organ remains highly active and crucial for energy and muscle retention, why does society, and honestly, often the medical establishment, continue to view older women's ovaries as retired or useless baggage?
It really reveals a deeply entrenched bias, one that equates a woman's biological value strictly with her reproductive capacity, while completely ignoring the profound endocrinological work her organs continue to perform for her own systemic health.
It really forces us to entirely rethink our cultural understanding of female biology at every stage of life. The body isn't a machine where old parts just power down when they are no longer making babies. It is a brilliant adaptive web. Even when the lights seem dim, the current is still flowing, doing vital, life-sustaining work right beneath the surface. Keep asking questions about your own biology. We'll see you on the next deep dive.